Hello, I'm Dr. Kimberly Ford. On behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for part 3 of a 3-part CMEO Pharmacist Central educational series entitled Beyond the Prescription Refill, the Role of Pharmacists in Ongoing Monitoring of Patients with Hepatitis B. The CMEO Pharmacist Central series is supported by an educational grant from Gilead Sciences. As I mentioned, I'm Kimberly Ford. I'm a hepatologist, associate professor of medicine in the section of hepatology, Department of Medicine, at Temple University Hospital at the Lewis Katz School of Medicine in Philadelphia, Pennsylvania. I'm very happy to welcome Dr. Lauren Heinecke to the program today. Dr. Heinecke is an associate professor of pharmacology at the University of Maryland School of Pharmacy in Baltimore, Maryland. Welcome, Lauren.
Thanks so much, Dr. Ford. I'm excited to be here with you today and talking about this very important topic.
First, I'd like to go over our learning objective for part 3 of this series, and that is to use interactions during hepatitis B medication refills to counsel patients about routine monitoring for hepatocellular carcinoma and hepatitis B reactivation. So Lauren, let's start with an overview of hepatocellular carcinoma. HCC is a primary liver cancer and a dreaded complication of chronic liver disease. It has the 8th highest mortality rate among all cancers. And to put this into perspective, its 5-year survival is approximately 18%. It's important to note that the incidence and mortality for other cancers has been decreasing while we see a continued increase in HCC, an increase that was approximately 38% over the period of 2003 through 2012. And that increase was driven by viral hepatitis. It's also important to recognize that there are differences between hepatocellular carcinoma that arises in the setting of chronic hepatitis C infection and that which we see in chronic hepatitis B infection. So for hepatitis B, there is a risk of HCC even in the absence of cirrhosis. Hepatitis B is a carcinogen, and it increases the risk of HCC by 50 to 100 times, while hepatitis C increases that risk by approximately 15 to 20 times. These distinct differences in epidemiology of HCC and chronic hepatitis B infection have important implications for making decisions about who to screen and when to screen. And many of the society guidelines that are in place, including that from the AASLD, specify the performance of surveillance for HCC in patients with chronic hepatitis B infection without cirrhosis, with cirrhosis, and also with a history of HCC. We're going to address some of this more specifically in the talk. Lauren, would you like to take us through a review of risk factors for hepatitis B associated HCC?
There's really 3 big buckets that these factors can be placed in. The first being host factors. So family history of liver cancer increases the risk for the development of liver cancer in patients infected with hepatitis B. We certainly know that older age, as people are aging, we see a higher rate of liver cancer developing in hepatitis B infected patients. Male sex is a risk factor for progression to liver cancer. There certainly are genetic and ethnicity factors that we're going to go into greater detail in a little bit. And then this next bullet is including diabetes and obesity. So really, with the development of metabolic syndrome and the obesity epidemic in the United States, there's been a higher rate of non-alcoholic fatty liver disease developing. And so having that disease state on top of the hepatitis B virus increases the risk of developing liver cancer. And then cirrhosis also would increase the rate of hepatocellular carcinoma. And in the last slide, you heard that patients with hepatitis B can develop liver cancer even in the absence of cirrhosis. But it's important to note that about 70 to 90% of those with cirrhosis and hepatitis B infection are going on to develop liver cancer. So there is a very high rate of progression in our cirrhotic patients. There are also environmental factors. This is our second bucket. So we know that smoking can increase the risk of developing liver cancer, as well as alcohol use. And certainly we know that alcohol is a hepatotoxin as well. So you're having two hepatotoxins, that would really increase the risk of liver cancer. Now, this last bullet, aflatoxin exposure, you may have never heard of this before. So this is pretty interesting, but aflatoxin is actually a hepatocarcinogen, and it's produced by Aspergillus species and is frequently found in undercooked food. So I think in our first module, we talked about the importance of fully cooking food, and it's really because of this hepatotoxin development in undercooked food that is the reason for that. There are also viral factors specific to the virus itself. So hepatitis B virus can integrate itself into the host DNA, and that itself can increase the risk for the development of liver cancer. And when they've looked at specific genetic sequences, they've found that the specific cancer sequence has been in close proximity to that hepatitis B integration into the host DNA. There's also factors related to virally translated proteins. Important to note, too, that in hepatitis B virus, there are at least 10 different genotypes that have been identified. So I think a lot of times we talk about genotype with hepatitis C, but not as frequently with hepatitis B. And so specifically, genotype C has been implicated as having a higher rate of developing liver cancer. We know that co-infection with other viruses, including viral hepatitis C, HIV, and hepatitis D, increases the rate of the development of liver cancer, as well as late antigen loss. And then finally, other factors include persistent elevation of liver function tests. So this is looking at really your ALT value, and when it's greater than 1.5 times the upper limit of normal, this can be associated with an increased rate of development of liver cancer or hepatocellular carcinoma. So that was a whole lot of risk factors, and probably really important to drill down on, I think, the racial and ethnic disparities. So Kim, I'm wondering, are there racial and ethnic disparities that we should be aware of related to the development of hepatocellular carcinoma?
Lauren, that's a really great question. So there are certainly racial and ethnic disparities. You also talked a little bit about some of the sex differences as well. This data comes from a study conducted by Salvatori and colleagues. They looked at liver cancer incidence rates from 1992 through 2016 in the SEER database, and they made some really important observations. And so liver cancer incidence was higher in men, and you talked about perhaps sex hormones influencing that incidence rate. Interestingly enough, the rate for men has plateaued. The rate in women continues to increase. And so we should think about that when we're thinking about, high incidence risk groups and who to screen, certainly. Rates tend to be low in whites, while much higher in other racial and ethnic groups. So highest in Asian and Pacific Islanders. Again, this rate was seen to have peaked in this particular group. The incidence was also quite high for American Indians and Native Alaskans. So again, I think that, this incidence data speaks to the need to screen, and particularly which groups may have increased risk of the incidence of HCC. So Lauren, what are some of the symptoms of HCCs that, pharmacists should be aware of in their patients?
So remembering that where the liver is located, I think, is the first thing to kind of start out with, to kind of put this into perspective. So it's in the upper right quadrant. So these first symptoms that you're kind of seeing, so right side upper abdomen discomfort, A lot of times when people complain about, and I always say quadrant because that's how they present when we're on medical rounds, but when they present about right upper abdomen discomfort, a lot of times people are thinking, oh, it's something going on in the liver. So that specific location for the discomfort can give you a clue that it's something related to the liver. Not always liver cancer, but it could. That's probably the big thing that you'd want to rule out when someone's complaining of right side upper abdomen discomfort. People may have a swollen abdomen, and that can be associated with hepatocellular carcinoma. So important to note that these things are not going to give you the exact diagnosis, but definitely are things that make you think, is there something going on with the liver that would prompt additional studies and really would make you think about telling them to go see their primary care doctor if they're not already established with a hepatologist. Patients may complain about a hard lump on the right side below their rib cage. That could be a symptom of hepatocellular carcinoma. Or pain near the right shoulder blade or back. So probably many of you are familiar with jaundice or the yellowing of the skin. I always think it's important to talk about scleral icterus too. I feel like that's the first place people notice a yellowing. So it's a yellowing or a discoloration of the white portion of the eyes. A few last things to talk about. So easy bruising or bleeding. And I think that this really drives home some of the things we talked about in module 1. A lot of this easy bruising and bleeding comes from a decrease in platelet count that we see in patients who have really advanced liver disease. They also might complain of unusual tiredness. Of course, this is going to be very non-specific, so I'm not sure you're going to jump straight to liver cancer or liver problems just with unusual tiredness, but along with some of these other things might lead you to think about a liver issue. Nausea and vomiting, again, kind of like unusual tiredness, one of those sort of non-specific things that we can see with so many different things. So probably looking at that in conjunction with some of these other ones. The loss of appetite and weight loss for no known reason, I think, are associated with many types of cancer. And oftentimes, to better assess this, one of my favorite things to ask my patients when they complain about weight loss is I ask about their pants and if their pants are fitting differently. And I also ask about belts, if they wear a belt and they've had to purchase a new belt or notice that they're using a different hole in the belt than they previously used, just to get a better sense as to the degree of weight loss that we're potentially talking about. So those are some of those big signs and symptoms. Kim, did you want to add, you look like you want to add something into the discussion.
I was just gonna, to your point about weight loss, certainly it could be associated with many things. As patients with decompensated liver disease continue to progress, you can certainly see weight loss, and in particular, some component of muscle wasting. But certainly when a patient comes to the office and they tell me, their clothes are baggy, they've had to change the size of the clothing that they're wearing, they haven't been intentionally trying to lose weight, I am certainly worried that an underlying malignancy is what we're dealing with. And I have to tell you, for the liver patients, it doesn't matter for me whether I've just screened them 3 months prior for HCC. It's something that I'm going to look for again. I'm very concerned when they come to the office with this complaint.
Do you have a sense as to the how quickly patients may complain about this weight loss? Is it over a particular period of time that you're looking for?
Sure. I would say that the recommendations that are currently in place for surveillance for HCC are timed out at 6-month intervals, and that's based on the potential doubling time of the tumor. But again, certainly I think even if you have thought about surveillance for HCC, you're up to date, and a patient comes in 2, 3, 4 months later with this complaint, I think it's worthwhile readdressing the issue.
Now it's really important to jump into talking about who's indicated for surveillance as it relates to HCC or liver cancer. So certainly in our discussion, we've already talked about patients with cirrhosis are really at increased risk for the development of HCC. So all people with cirrhosis, including people who seroconvert or have hepatitis B, but basically lose that hepatitis B surface antigen. So they become hepatitis B surface antigen negative. So they've had that seroconversion. They still need to be screened for hepatocellular carcinoma if they've already developed cirrhosis. And then you've already heard that hepatitis B really increases the rate of development of hepatocellular carcinoma, even in the absence of cirrhosis. So there are some specific recommendations for screening in people who have not yet developed cirrhosis, but who we know are at increased risk for developing liver cancer. So Asian or Black males who are over 40 years of age should be screened for liver cancer. Asian females older than 50 years of age should also be screened for liver cancer. People who have a family history of hepatocellular carcinoma, so we've heard that that family history is an important risk factor that we should be considering. And then finally, people with hepatitis D virus co-infection should also be screened because of the increased rates of hepatocellular carcinoma. So we now have an understanding about who we're screening, but many pharmacists probably are not terribly familiar with exactly what surveillance methods are used and even the frequency that these surveillance methods should be done in these patients. So Kim, would you be able to tell us a little bit more about the surveillance methods that are used and the frequency with which they should be done?
Absolutely. So it's recommended that patients at risk for HCC, as you outlined in the prior slide with hepatitis B infection, undergo a surveillance method. What is recommended is an abdominal ultrasound with or without alpha-fetoprotein every 6 months. For me, when I was doing my training, I used abdominal ultrasound and AFP, and I still continue to do that. I think that, many times you can pick up an elevated AFP, and that is of concern, and that prompts me to get additional imaging, and we'll talk about that in a minute. But I do think that there is some information that can be obtained from following that alpha-fetoprotein, and so I certainly continue to do that in my clinical practice. An MRI with and without contrast or a CT scan, that is a triple phase CT scan, is needed for the evaluation of suspicious lesions or, as I noted, if the AFP is elevated. It's important to note that hepatocellular carcinoma is one of really a handful of cancers that can be diagnosed without liver biopsy. So the imaging has various characteristics that help us to make a diagnosis. And if I'm not mistaken, I think only renal cell carcinoma is the other cancer that can be diagnosed radiographically. So what we tend to look for on MRI or on CT scan is, mass lesion. There tends to be enhancement. So the lesion really lights up as blood is going through the liver. And so the lesion is getting its blood supply from the hepatic artery, which is why it lights up. For some, it tends to have a pseudocapsule or a thin rind. I think of it as, the skin of a lemon versus the skin of a grapefruit. That's what I mean by a thin rind there. And then you also want to see the contrast washing out as blood is transiting out of the liver. And so that's called venous washout. And if you've had a lesion that is small, that has grown at least 50% between your imaging studies, that would also suggest that hepatocellular carcinoma is the underlying etiology. But again, this constellation of radiographic symptoms is how we can certainly diagnose hepatocellular carcinoma. Of course, if there is a concern that maybe a mass lesion represents another type of cancer, a biopsy can certainly be performed in that setting.
Do we have any evidence that supports these monitoring practices in hepatocellular carcinoma?
So there was a great study that was presented a few years ago at the liver meeting by Shim and colleagues. And it very nicely illustrates the effectiveness of follow-up on HCC in regards to two aspects of care. And outcomes. So the first is receipt of curative therapies, and the second is liver cancer-related death. So this was a large cohort of patients with chronic hepatitis B infection, so over 400,000. Some patients underwent regular follow-up, and that was pretty loosely defined. They had to be followed by a physician during that period of time, and they didn't specifically look to see if patients had appropriate surveillance. It was just follow-up in the medical system. And regular follow-up increased the likelihood of being able to undergo curative therapies. So this could have been liver segmental resection. It could have been use of liver-directed therapies for the treatment of cancer. And there was also a reduction in risk of death. So a 44% reduction in risk of death over this study. And you can see from the different columns here, while regular follow-up was certainly most effective or impactful on the natural history here in these patients, even a regular follow-up, so some follow-up during the study period, was important in decreasing the risk of liver cancer death. I think that this particular study in a very large population demonstrates the importance and the value of follow-up, certainly in the setting of HCC. And I think it speaks to the fact that we have to think about working collaboratively to get patients appropriate follow-up. So if you actually look at this, only about 23% of the cohort received regular follow-up, and 19% received no follow-up at all. So I guess, my question is, since we need to involve everybody who is taking care of the patient, Lauren, what can pharmacists do to be sure that patients stay on track with their monitoring in the setting of chronic hepatitis B infection?
Kim, I think that that's a really great question. And I think that this may not be an area that many pharmacists have specifically thought they have a role in. So, I think we're going to throw out some ideas, but there's going to be lots of opportunity for discussion. So we'd love to hear your thoughts as well. The thoughts that we had about the role of the pharmacist is that, you may be able to identify patients who will require that HCC monitoring based on specific medications you're filling in their pharmacy. So certainly if you have a patient who's on chronic treatment for viral hepatitis B, that's relatively easy to identify if they're mono-infected, right? So you're looking for specific medications that you would use to treat that viral hepatitis B. Of course, if you tuned into our first module, you know that Hep B and HIV have similar transmission risk factors. So you could have a patient co-infected with HIV and hepatitis B, and because we have so many HIV preparations that contain our tenofovir salts, you might not know that they have hepatitis B because they're serving sort of a dual purpose. So they might be harder to identify, but your patients who are only receiving that tenofovir salt will be much easier to identify. The other thing that I think you could look for in terms of medication refills is you could look for specific medications used to treat the complications of cirrhosis. So I think a lot of these will probably jump out at you, even though there's medications that are in that class used for different disease states. There's specific medications we use for treatment of cirrhosis complications. So I'm not going to belabor these or give you any PTSD from when you were in pharmacy school and had to learn about them, but just to quickly highlight, certainly if you have a patient who has ascites, they could be receiving treatment with furosemide and spironolactone. You always see that dual combo in the ratio of 40 to 100. And we know that that's the specific ratio that's needed to maintain the normal kalemia. Certainly, we also have patients with cirrhosis develop hepatic encephalopathy, and then you're looking for your lactulose. And then certainly the other medication that you might think about is rifaximin. So it's our non-absorbable antibiotic that can be used to decrease the bacteria in the GI tract that produce ammonia. And there has been specific dosing approved for hepatic encephalopathy. Previously, it was that 400 Q8 that was used when we only had that 200 milligram capsule available. There is the 550 capsule that should be twice a day, and that's going to be what's used for our patients with hepatic encephalopathy. So then thinking about other potential complications, certainly variceal bleeding is something that these patients can experience. And, really you're looking for those non-selective beta blockers that are working at a specific location to decrease the blood flow to that portal vasculature to decrease your risk of bleeding. And when you're thinking about those non-selective beta blockers, there's actually not a ton. The two that you're probably most familiar with are nadolol and propranolol. If you see those, you can almost guarantee, unless you've got an older physician prescribing, that it's being used as variceal bleeding prevention, either primary or secondary prophylaxis. And then I think maybe the hardest in terms of identifying a specific medication is spontaneous bacterial peritonitis. It used to be that if you saw the fluoroquinolone, ciprofloxacin once weekly, you could know that they had an episode of SBP and were receiving prophylaxis against future episodes. Of course, now we know that intermittent antibiotic dosing leads to resistance, and so it's not recommended at this point.
We still use Cipro in addition to Bactrim, but as you pointed out, not at that once weekly dosing.
So the antibiotics are not quite as a slam dunk, but hopefully that gives you a little bit to think about in terms of what medications you might be seeing that would trigger you to think this is a patient who has cirrhosis and complications, and you might want to think about, talking with them about the importance of screening for hepatocellular carcinoma. I think that sometimes the more people hear the recommendations in different settings from different providers, the more it really sticks. And I think especially, like, I found if I go into a counseling session for a patient and I show them what I'm looking at and why I'm concerned, they're a lot more likely to engage in the conversation and to have a better, I think, understanding about how they can be an active participant in their healthcare. So hopefully we've given you some helpful clues about how you could potentially think about identifying these patients, and then thinking about talking to them about why it's important to screen for hepatocellular carcinoma in those high risk groups that we've talked about. Some tips you can use when you're thinking about counseling them. So you want to educate them about regular follow-up and monitoring for disease progression. And at a minimum, this should be every 6 months. You can talk to them about the long-term implications of chronic Hep B infection. So it's important, they may not fully be aware of what can happen in terms of if they are not getting their disease under control and having follow-up at the risk of cirrhosis. And certainly I think not just cirrhosis, but talking about those complications that can develop is important to really help them fully understand the implications. And of course, hepatocellular carcinoma or liver cancer. You want to talk with them about making sure that when they see medical providers, that they make them aware of their hepatitis B surface antigen positivity status. It's important for all providers to be aware of this in terms of being able to best select treatment for cancers and immunologic conditions. We're going to talk about why this is so important in really the sort of second portion of our talk today. Certainly, in terms of alcohol use, it's important to counsel them about avoiding or limiting them, since we know that alcohol is also a hepatotoxin. So we want to decrease any additional stress on the liver by limiting alcohol use. And then in terms of body weight and addressing metabolic complications, I've mentioned briefly non-alcoholic fatty liver disease. So it's important, I think, in these patients to think about all of the potential things that could influence the risk of progression. And that certainly includes weight management and prevention of the risks of non-alcoholic fatty liver disease.
So thanks for those really helpful tips. Now we're going to discuss a topic that I would say is perhaps not as publicized, but just as important. And that's for healthcare providers to be mindful of reactivation hepatitis B. So there are new targeted treatments and biologics that have really revolutionized the treatment of patients with cancer, those with autoimmune diseases, and those requiring organ transplantation, such as stem cell transplants. But their use may be associated with reactivation. And depending on the mechanism of action of these immunosuppressing drugs, there's a differing level of risk of reactivation. We can certainly see hepatitis B reactivation in those patients who are co-infected with hepatitis C infection and being treated with direct-acting antivirals. So it's something to be mindful of in that situation as well. And it's pretty important, that we deal with these issues as patients are being considered for therapy. And that's for this immune suppressing therapy, because disruption of treatment can really have a profound effect on disease control and overall survival, depending on the indication for treatment. So with hepatitis B reactivation, the immune suppressing medication results in a loss of immune control of the virus. And then there's subsequently an increase in the hepatitis B DNA in someone with chronic infection or prior exposure. A hepatitis flare can then be experienced, which results in an elevated ALT. And some patients, while they may be asymptomatic, others will develop severe liver injury and could potentially go on to death. Regardless of the severity, the goal is really to prevent a flare so that the immunosuppressive treatment does not have to be delayed.
We need to talk a little bit about the definitions of hepatitis virus reactivation and a hepatitis flare. Now, I will tell you that if you go into the literature to take a look at studies related to hepatitis B virus reactivation, for quite a while it was not well defined. And so a lot of the studies looking at hepatitis B virus reactivation, there's a lot of heterogeneity in terms of how it was defined in these different studies. So more recently, some of our national and international liver associations have developed some specific definitions that have really, I think, allowed for a more cohesive discussion of these particular topics. So again, just to orient you to these organizations that you may or may not be familiar with, you're probably familiar with AASLD, but you may not be as familiar with the other two. So AASLD is the American Association for the Studies of Liver Disease. This is our US-based organization. The center column is EASL, or the European Association for Studies of Liver Disease. And you see that these are undefined criteria. So I'm not going to refer back to EASL much at this point. And then APASL is the Asian Pacific Association for the Study of Liver. So, and that's an organization that you may not be as familiar with. So I thought it was important to let you know what those organizations are. So AASLD defines a reactivation of hepatitis B as an elevation in the Hep B DNA compared with baseline, or an absolute increase if the baseline is unavailable. The other interesting component to that definition is it says seroconversion, but when I think about it, I almost think about it as reverse seroconversion, if you will. So when we talk about patients with hepatitis B, we think about them being positive for that hepatitis B surface antigen. That's our marker that they have an active infection. And so if they convert to be hepatitis B surface antigen negative, that's a marker that they've been able to clear the infection. But what you can effectively see is that they've cleared it and then they reactivate. So they become surface antigen negative and then become surface antigen positive. So it's almost like a reverse seroconversion is effectively how I've seen it described in the literature. In terms of APASL, their definition is a greater than 2 log increase from baseline in the levels of the hepatitis B DNA, or a new appearance of a hepatitis B DNA to a level of greater than or equal to 100,000 international units per milliliter in a person with previously stable or undetectable levels. And the second part is a detection of Hep B DNA level greater than or equal to 20,000 international units per milliliter in a person with no baseline Hep B DNA. So this is sort of nice. They give you information for someone that you have a level for, and then information on someone where you don't previously have a level for. And I like this kind of specific definition to augment the AASLD definition. Moving on to the hepatitis flare, it's defined by AASLD as an ALT elevation greater than 3 times baseline levels and greater than 100 units per liter. APASL defines it as an intermittent elevation of seroaminotransferase levels to greater than 5 times the upper limit of normal and 2 times the baseline value. So I think it's important to kind of point out some of those differences. Certainly, we know that there's variability in patients' baseline values for these aminotransferase levels. There could be various reasons for that. So I think it's nice that they kind of have that additional definition of baseline as well as upper limit of normal, because certainly we have patients that at baseline have elevated levels. So it's nice to sort of have both of those in there. The other thing I wanted to point out sort of related to this definition is that the ALT generally rises before we have an increase in the Hep B DNA. And in my reading, it suggested that the ALT is elevated about 2 to 3 weeks before you see that elevation in the Hep B DNA. So I think it's important when we think about Hep B reactivation, we're not just looking at evaluating the Hep B, but it's important to get a complete metabolic panel to really look at a comprehensive view of the liver. Kim, any other thoughts in terms of your clinical practice, in terms of what you've kind of seen related to reactivation or hepatitis flares in these specific lab values?
You do tend to see the ALT rise first. Some of the recommendations that I'm going to go over in those patients who have had prior infection, which is now resolved, there is a recommendation to not only check the hepatitis B DNA and some to check the hepatitis B surface antigen, but also to check that ALT every 1 to 3 months. And certainly a rise in the ALT is going to suggest that something is going on. And I agree, you'll tend to see the hepatitis B DNA rise thereafter. You know, perhaps it speaks to some replication that may be going on in the liver that may not be appreciated in the serum sample at the time that we're seeing the ALT rise. But regardless, I think it's important in clinical practice to make sure that people are also getting that metabolic profile to see what the ALT is. For those of you who have been following this series, if you've been looking at part 2, and I guess if you haven't looked at part 2, you should perhaps look at part 2, because we do talk about how the ALT has changed over time, and our threshold for determining whether an ALT is normal or not has changed over time. And I think that that's a very helpful discussion, certainly in the setting of hepatitis B. The thresholds that are now utilized by AASLD and other organizations include a ALT level of 19 for women and 30 for men. So anything over 25 would be abnormal for a woman. Anything over 35 would be abnormal for a man. So just something to think about as we're thinking about those normal ALT levels. So I'm going to just review the different recommendations from the societies that we have. And I think it really will help to focus people as they think about who might need to be placed on prophylactic therapy so that hepatitis B reactivation can be avoided. So regardless of the algorithm that one uses, the first step, and perhaps the most important step, is to screen for hepatitis B infection. And I think that this is a really, really important point. And we're now starting to see the specialists, our oncologists, our rheumatologists, our IBDologists who are getting ready to start their patients on therapy. They're now starting to screen for hepatitis B infection. And it's important to screen with either 2 or 3 serologies, the serologies that Lauren outlined. So we can see that all of the societies suggest screening. Screening should at least include sending a hepatitis B surface antigen and a core antibody, with EASL also suggesting that antibody to hepatitis B surface be sent as well. In clinical practice, I usually will evaluate patients for all 3. I actually think that evaluating a patient to determine whether they've been vaccinated is important, and certainly making sure that they receive vaccination if they're found to be susceptible is also an important part of the management here. For status, so hepatitis B status is really an important breaking point here when we talk about the algorithm for whether patients go on to prophylaxis or whether they will go on to monitoring only. And you can see each of the societies uses chronic hepatitis B infection versus resolved infection. So chronic hepatitis B would be those patients with a hep B surface antigen that's positive. Those with resolved infection would have a negative hepatitis B surface antigen, but a core antibody. And you can see with all patients with chronic hepatitis B infection, they should be started on prophylactic therapy. We'll talk about that in a second. Lauren mentioned this earlier in the talk. Really important to do that because the risk of reactivation in patients with chronic hepatitis B infection is so much higher than it is in those with resolved infection. We see also those patients with resolved hepatitis B infection who are going to be treated with what we consider high-risk therapies. So those therapies that are associated with the highest risk of hepatitis B reactivation. And primarily we're looking at agents like rituximab or organ transplant states such as stem cell transplant. All of those patients, I should say, essentially all of those patients would go on to prophylaxis here. We can see the Apostle recommendations kind of diverging here, where it says rituximab in lymphoma, either prophylaxis or monitoring, and they're calling for further studies, but certainly what I do in clinical practice, because I think that the risk is so high with rituximab, is that I will put those patients on prophylaxis before starting. The area where there is some divergence in recommendations is really the group of patients with resolved hepatitis B infection who are going on other therapies. Therapies that are of moderate risk for reactivation or low risk for reactivation. And so this could include anti-TNF therapy, high-dose steroids, et cetera, where some of the societies are recommending either prophylaxis or on-demand therapy where you're monitoring every 1 to 3 months with at least ALT and the hepatitis B DNA. Apostle recommendations suggest that you check for a hepatitis B DNA in those patients with resolved hepatitis B infection. And if they have any detectable level of hepatitis B DNA, starting on prophylactic therapy. So what do we use for prophylactic therapy? We use high potency agents that are associated with very little resistance. And so our choices include entecavir, tenofovir, this is the disopropyl fumarate preparation, and then TAF is the alafenamide preparation. The TAF version of this for those patients with some degree of renal dysfunction or perhaps some degree of bone disease. But those are the 3 agents that I choose from when I'm thinking about prophylactic therapy. I will place patients on these medications and continue at least until they are off of their immune suppressing regimen for 12 months. You can see some of the societies, so specifically EASL, suggesting that patients who are on rituximab should continue to get prophylactic therapy up to 18 months after they discontinue their rituximab, including immune suppressing regimen. And then for patients, we'll tend to suggest follow-up after that. So even after that 12 to 18 months after they've been off of therapy, continuing to monitor them. So while I think that there is divergence here in some of the recommendations, I think it's always more important to err on the side of caution. And if you're concerned that a patient is at increased risk of reactivation, that you use prophylactic therapy. So with that, let's summarize our discussion with SMART goals. So specific, measurable, attainable, relevant, and timely. That's, of course, what we hope that you will take away from this talk today. And so our SMART goals are the following. With each hepatitis B medication refill, that we seize an opportunity to educate patients about hepatocellular carcinoma, that we ask about regular monitoring and surveillance for HCC, that we heighten awareness for hepatitis B reactivation and query patients receiving immune suppressing therapy about regular monitoring by their healthcare providers. And lastly, that we advise patients to inform all current and future medical providers of their hepatitis B surface antigen positive status, especially if they ever need treatment for cancers or other immune disorders. So Lauren, with that, I think it's time for us to let our audience join the conversation and ask some questions. So good evening. Welcome to the Q&A session. So we already have a number of questions in the chat box. So let's go ahead. So one of the first questions posed, I'm going to hand this off to Lauren. So as a pharmacist, should we be asking all patients who are undergoing chemotherapy or being placed on a biologic whether they have been screened, regardless of whether they're taking hepatitis B treatment or not? And I know Lauren has encountered this particularly in the setting of having to treat hepatitis C patients, and that's kind of a natural way to open up the discussion about Hep B. But is this a strategy that you have incorporated into the remainder of your clinical practice?
Yeah, this is a great question. And I think that I would say yes. I think that asking patients if they have been screened in advance of this therapy is a great way to make sure there's another double check in place so that we're making sure patients who do need to be on prophylaxis are on prophylaxis. You could also ask them if they've been vaccinated. So you don't just have to ask if they've been tested, but they may also remember receiving the vaccine. So I would say yes, absolutely, that this is a great opportunity to make sure that everything that's needs to be done prior to getting started has been done for these patients.
I echo those thoughts, certainly. You know, in the clinical space, I think as well. And so I would use that as an opportunity. The other part of the question was about, you know, how many patients may this affect? And so in the US, hepatitis B is of low endemicity. And so we expect that that's going to be anywhere from 2% or less. But unfortunately, without getting the appropriate screening, we're not going to know. So again, I think opening up that line of communication and providing a double check for the screening activities is really quite important. So going back to the chat, there was a question about how to teach patients more about hepatitis B transmission and prevention with family members. So, Lauren, do you want to first discuss your approach, and I can talk a little bit about my approach?
So I have to tell you, I don't do a huge amount of this in my practice. A lot of what I'm doing is counseling on the medications. Most of the time, by the time they've gotten to see me, there's already been some discussion discussion about this. A lot of, and I see a lot more hepatitis C patients than Hep B, as you've already heard. There's low endemicity of Hep B in the U.S. So, but I will say I talk a lot about reinfection with hepatitis C. So I think it's really important for patients to understand how they could have contracted it in the first place. I also see a lot of patients in an HIV clinic, so we talk a lot about safe sexual practices. So I think those are some of the biggest things that I do in my clinic in terms of talking about prevention. And a lot of it does carry over into things you would talk about with hepatitis B, although not so much the reinfection piece of that.
So I certainly do a little bit of education. I first start off by going over that it is a bloodborne virus. And in places where the rates of hepatitis B are high, that usually there's transmission within families. So that may be transmission from mother to child, that may be transmission in households. I talk a lot about mucosal exposures and being aware of potential exposures with toothbrushes and razors, personal care items, nail clippers, things of that nature. And then I round out the education by really emphasizing that everyone in the household should be tested, and based on their immune status, they should be vaccinated. And I tend not to do this only once, but usually every time the patient comes back, I'll inquire as to whether people in the household have been tested and appropriately vaccinated. So that's usually how I provide some education around the issue of transmission. Going back to the chat, there were a few questions about hepatocellular carcinoma. And so one of the questions was referring to why shoulder or back pain? What's the connection to liver cancer here? And it's really a connection with any kind of process going on in the right upper quadrant of the abdomen. So there tends to be referred pain. And so radiation of pain up to the shoulder or to the back. You can also see that in the setting of gallbladder disease. And so it's not specific to liver cancer, but it is something that patients may present with. There was also a question about potential symptoms of reactivation and educating patients around the issue of reactivation. And I would say that sometimes patients have absolutely no symptoms at all. And when we do start to see signs and symptoms that their liver is not working in the setting of hepatitis B reactivation, it might be quite advanced. And some of those symptoms would include jaundice, so yellowing of the eyes or the skin, abdominal distension from ascites, confusion from hepatic encephalopathy. I think the point to really emphasize is that, the blood work that is being asked of them for continued follow-up while they're being evaluated for or continue to be followed for reactivation can tell us early whether they're starting to have signs of reactivation. So you usually see an elevation of the ALT, and then you'll see an uptick in the hepatitis B DNA. So that laboratory data is really important. And being on top of that, I think, is one of the important points to make if patients are not being initiated on therapy at that point in time. So this is a question for Lauren. What programs are in place that can help with HCC surveillance methods that can be utilized in the pharmacy? And I don't know if you have any such methods in place. I can talk a little bit about how various places have tried to kind of harness the electronic medical record to give prompts. So I can talk about that in a second. But Lauren, do you have thoughts?
I think that this is a really challenging question, and we don't have anything specifically in our clinic to track these types of patients. We have Epic as our electronic health record, so I think a lot of it depends on the electronic health record that you have, the types of things that you could use. I think there was a question about how to keep track of them. There are sticky notes that we have in Epic that you can kind of make notes. I think it's only you who actually sees them, so it's most helpful for you to make reminders to yourself when you're seeing the patient back frequently. So that could be a tool that you could use in your own clinical practice. There's also patient lists that you can share with colleagues. So that's another way that you can have a list to maintain the patients that you want to make sure maybe you're doing some quality assurance on to make sure that they're having the appropriate testing at the appropriate times. And you can shift patients on and off those lists. So I think those can be helpful if you are good at maintaining them. I am not good at maintaining mine. So my lists are not terribly helpful. Honestly, we have an IT person who, when I really need data, he runs that data for me. And we have programs within our clinic they're really more pharmacy adherence programs where they run the data every month. And then it's a way for us to go in and look at the chart to sort of target specific adherence issues within our patient population. So those are some of the things that I've used in my clinical practice that I could see being helpful.
So a few years ago, I was involved in a study where we tried to implement a best practice alert into our electronic medical record. And number one, it was difficult because of the programming required. And then number two, it depended on who was actually seeing the message and whether there was any subsequent follow-up in that regard. So I do think that there are ways to utilize the electronic medical record. We're probably not as good at that as we should be, but that's also something to think about. So just two more questions, or I should say one more question and a comment, because I thought it was a very insightful way to kind of open up discussions with pharmacists and patients. So the first question is, what can pharmacists do at the retail level to use interactions, especially when you may have little time, you're busy, you want to do some counseling, and how might you be able to address the issue of hepatitis B reactivation? So Lauren, have you come across information about potential interactions in your patients, and how have you used that opportunity to do some counseling?
Yeah, I think this is a real challenge that I think a lot of pharmacists would identify and talk about in their practice setting. So it has been a few years since I've worked in a community pharmacy setting, but I have to tell you, when I was moonlighting during my pharmacy residency, my favorite stores to work in were so I was in Richmond, Virginia at that point in time, and they were in some of the worst parts of Richmond because they were generally not busy, and my patients wanted to talk to me, so I was able to do a lot of glucometer counseling. So I don't know if you have any ability to choose your location where you are, but I hated working in the suburbs of Richmond because people were making me get milk as I was filling their prescriptions in the drive-through. But so I definitely can identify with those challenges. I think that, one of the things we do need to be cognizant of, and I think we talked a little about during the program, is just the stigma with hepatitis B. So I think we do want to be careful about how we bring it up and when we bring it up, and making sure that we're in a private type of environment so it's just us and the person and they feel comfortable talking with us about it. I do think that when I've been in pharmacies, one of the times that I think would be ideal to talk with someone about different types of things is when you're giving them immunizations. Usually at that point in time, you're in a private area and you are giving them the immunization. So you have some time, they're a captive audience, and they've asked to come and get that immunization. So I think that that's an ideal time. Obviously, not every single patient picking up their medications for hepatitis B or cirrhosis is getting an immunization. So I think we if you have the time and the ability to say, hey, I was hoping just to talk with you a few minutes about your medications. We're trying to do some more comprehensive medication reviews. I noticed someone had mentioned brown bags, and I think that bringing that up is worthwhile. So having programs within your pharmacy that really give patients the opportunity to come in and ask you questions where you're planning to have additional time and maybe private space. So I don't think I have that all figured out. I think honestly, the people in this seminar who work in the community setting probably have better ideas than I do, because I'm lucky to practice in a clinic where they're my captive audience. So, but those are just a few things that I would kind of think about in terms of optimizing your communication with patients in the community pharmacy around hepatitis B.
I'm glad you mentioned the brown bag lunches, because I thought that was a fantastic recommendation for, opening up those lines of communication, particularly around medications. Unfortunately, our time today is coming to an end. We've had many great questions, and I'm so sorry that we're unable to get to all of them today. But before we go, I just want to remind you of the key points or the SMART goals from our program tonight. They are with each hepatitis B medication refill, seize opportunities to educate patients about hepatocellular carcinoma, ask about regular monitoring and surveillance for HCC, heighten awareness of hepatitis B reactivation, and query patients receiving immunosuppression about regular monitoring by their healthcare providers, advise patients to inform all current and future medical providers of their hepatitis B surface antigen positive status, especially if they ever need treatment for cancer or other immune disorders. So again, thank you to our audience for all the great questions you sent in this evening. If any of your colleagues missed tonight's program, please let them know that there's another live credit opportunity available on Wednesday, July 28th at 10 o'clock a.m. Eastern Time. For additional clinician and patient resources, please visit CMEO Pharmacist Central at cmeoutfitters.com. Stay safe, and thank you again for participating and for providing the best care for your patients. Have a good evening.